Hello, and thank you all for joining our latest session in the quality webinar series. Let's talk about outpatient revenue cycle and uncovering real opportunities. Today's speakers will be Sue Belley and Nichole Soderquist. And without further ado, I'll pass it over to them.
Thank you for joining us today for an in-depth discussion on the complexities of managing the outpatient revenue cycle, including how it differs from the inpatient revenue cycle and requires a customized strategy for the diverse outpatient environment. We'll explore unique challenges and strategies to surface opportunities and maintain ongoing surveillance to improve the health of the outpatient revenue cycle. Nichole and I will be sharing this presentation on the outpatient revenue cycle today, and we'll be handing it back and forth to each other. What is your role in relation to the outpatient revenue cycle? All of the areas and roles you see on screen, plus many others, are involved in the outpatient revenue cycle in one way or another. Everyone has input in the outpatient revenue cycle and has a vested interest in the output of this revenue cycle. When I talk with people about their outpatient and professional revenue cycles, I ask them how they keep up and manage all of the different facility outpatient departments and professional arenas. It's very difficult to keep abreast of it all. When I talk with people about their outpatient and professional revenue cycles, I ask them how they keep up and manage all of the different facility outpatient departments and professional arenas. It's very difficult to keep abreast of it all. Please take a minute and look at this scenario of a patient who presented to the emergency department and required CPR followed by endotracheal intubation. What do you see when you look at the charges from the claim for this encounter? What I see are two charges for the endotracheal intubation with two different revenue codes. Furthermore, I noticed that the charge amount is different for each. So what's going on here? It appears that the respiratory therapy department posted a charge for their involvement with the placement of the endotracheal tube, and it also appears that the emergency department posted a charge for the same service. Since charges can't be posted twice, what should the facility do? Should they try to clean it up on the back end as the claim moves along in the revenue cycle and delete one of the charges? Or should they take a proactive approach and talk to both the respiratory and ED departments and to determine who should post the charge moving forward? The hospital will also need to address why there are different charge amounts for the same service and rectify this. I also note that there are two different revenue codes for CPR administration. It's really the same situation as we saw with the endotracheal tube placement. The only difference here is the charge is the same for both revenue codes. Once the fixes are put in place, does the hospital move on and hope everything works correctly? Or do they monitor to see if these problems are truly corrected or if further intervention is needed? The outpatient revenue cycle is complex. We saw an example of these complexities in the previous emergency department scenario we discussed. These are some of the factors making it complex. First, there is a large variety of outpatient encounter types: emergency department, ambulatory surgery, observation, interventional radiology, infusion clinic, wound care. I say the larger the facility, the more outpatient departments there are. And then there are different documentation, coding, and billing requirements for these different encounter types. Many different hands touch and influence the revenue cycle before and after coding has been performed. As an example, an incorrect admission for an observation encounter or a billing specialist deleting or adding a modifier to clear an edit can wreak havoc on claims. Then there are frequent billing and coding updates and changes that occur. This was especially evident during the public health emergency for COVID, when we learned of new CPT and HCPCS codes for vaccines almost every other week there for a while, or the changing guidelines for telehealth codes. These are just some of the things that contribute to the complexity of the outpatient revenue cycle, making it difficult to keep eyes on all the moving parts of the revenue cycle to ensure that they are functioning correctly. Is the outpatient revenue cycle more complex than the inpatient revenue cycle? Let's look at the differences. In the inpatient setting, the focus is on a single patient type, single encounter type. In the outpatient setting, the focus is on multiple encounter types. I just mentioned on the previous slide, uh, emergency department, ambulatory surgery, observation, wound clinic, etc. In the inpatient setting, patients typically stay at least 2 nights or greater. In the outpatient setting, visits can be anywhere from a few minutes to few hours, definitely short stays. In the inpatient setting, physicians and providers are typically able to arrive at definitive diagnoses with associated treatment plans achieved. In the outpatient setting, diagnoses often include signs and symptoms and a diagnostic workup with not enough time in the encounter to always conclude a diagnosis. In the inpatient setting, we've had formalized, long-standing CDI programs available 30 plus years in many cases. In the outpatient setting, CDI programs are really in their infancy, and the industry has not, really been able to clearly define what an outpatient CDI program consists of. In the inpatient setting, we typically see credentialed coders performing ICD-10 code assignment. In the outpatient setting, we achieve code assignment in a variety of ways. It can be the physician or the advanced practice provider assigning codes. There can be a coder. Codes can be charge master driven. Codes can be system driven through simple visit coding, for example. And in the inpatient setting, from a reimbursement methodology perspective, we focus on DRG methodology. In the outpatient setting, there are multiple reimbursement methodologies such as APCs, EAPGs, the physician fee schedule, risk adjustment. So if you ask me, I think the outpatient revenue cycle is more complex than the inpatient revenue cycle. So at this point in the presentation, I'm going to turn it over to Nichole.
The outpatient revenue cycle is complex, and we see many different types of challenges in both facility services being rendered as well as those on the professional side. We're going to take a few minutes and discuss some of the common challenges that we see on both sides and that have an impact on the revenue cycle. I want you to think about your current processes as we discuss each of the challenges and ask yourself if these are challenges that you currently face or are they areas that have not yet been explored within your organization. So if we're talking about the revenue cycle challenges on the facility side, we often see items such as medical necessity edits bypassed. This could occur when a GZ modifier is appended and documentation actually supports medical necessity, but the condition that was documented was not final coded. This is where it becomes important to go back and check the documentation to ensure that everything was coded. Another challenge is the inappropriate application of modifier 59. An edit may appear between two CPT codes. A 59 modifier was added to bypass this edit, regardless if the criteria was met for that 59 modifier to be present. So if this is not happening at the coding level, we do see it being appended by billers on that back end to get that claim out the door. I want you to think about the CMS criteria for appending modifier 59. Do you truly have a distinct service and documentation that supports that different session, a different procedure, different site, organ system, separate incision, separate injury, that is not ordinarily encountered or performed on the same day by the same individual? Additional challenges are inaccurate reporting of observation hours. There are several components to billing for observation services, and one of those is carving out time when the patient is receiving services off the floor. What this means is anytime that the patient leaves the observation unit, let's say, for example, EEG needs to be done or an echocardiogram, and the patient is no longer being observed on the floor, we need to carve out that time that they are gone from the total observation hours. I want you to think about how you're capturing observation hours now. Who is doing this? Is it automatic? Are they accurate? Conflicting orders for patient status is another challenge. Is the patient supposed to be placed in observation, an admission to an inpatient, or are they supposed to be in extended recovery? Think of the example of a patient has a late same-day surgery operation and they still need to meet discharge criteria before going home. The patient is inadvertently placed in observation rather than extended recovery. We see this done a lot, and the patient does not meet observation status. Missing charges for procedures and/or supplies. Think about your skin graft supplies, catheters used in interventional radiology procedures, blood products during blood transfusions. Are these being captured accurately? Incomplete documentation is another challenge, especially when it comes to the capture of chronic diseases. Were these chronic diseases treated, assessed, impacted during that current encounter? This could play a role within HCCs as well. Inpatient-only procedures not identified in time to get the order prior to surgery. You may see this happen if the procedure is changed during the operation, an incorrect CPT code being used for pre-authorization, or an incorrect CPT chosen by coding when the bill went out. Over and under coding are additional challenges. Think back to the example provided earlier with the emergency department and respiratory therapy reporting endotracheal tube insertion twice. Inaccurate coding. Are your coders in-house or outsourced? Do you have a policy for auditing or education? These are all challenges because they impact the revenue. I have a scenario I'm going to take us through on an observation case. We will read the case, compare what was billed, and then we're going to go through it, and I want you to think about, was it good documentation or are there areas of opportunity? We read through this scenario, I want you again to think about that documentation, and I will show you what was billed as well. But some of the key points that we are going to focus on here are the medical necessity, the observation hours, and infusion therapy. So we have a 78-year-old female who came into the ED for redness and pain of the right forearm. Clindamycin infusion was started at 9:08, ended at 9:39. Patient was placed in observation with a diagnosis of cellulitis, and they were to continue the IV antibiotics. As we continue on, the observation order was written at 10:35. A second IV infusion of clindamycin was started at 10:50, which ended at 11:21. The patient continued to complain of the right forearm pain. After the second infusion, the attending physician ordered Toradol IV for the pain and a limited Doppler of the right extremity. So the patient was given the IV Toradol at 13:10. Transport came and transported the patient from the observation unit to the vascular lab for the procedure. Upon return to the observation unit, the patient received another infusion of clindamycin, which started at 15:30. The progress note at 1700 states that the patient has improvement in the swelling and the erythema and pain-free. So the vascular study was negative. Patient felt comfortable to go home. The physician wrote the order for discharge at 17:53. Discharge instructions were reviewed. IV was removed by nursing at 19:20. The daughter could not pick up the patient for another hour, so 20:30 the patient was taken to the exit with all discharge paperwork and belongings. Let's take a look at what was coded that corresponds with the scenario we just discussed. Reason for visit, first listed diagnosis, we have the cellulitis of the right upper limb. We notice from the CPT code, we have the ED visit for the evaluation and management service. We have 10 hours of observation time. We have an initial 1 hour infusion. We have an sequential IV push. We have an additional initial 1 hour infusion with an XU. And then we have that duplex scan of the extremity. On the previous slide, how we were going to compare the codes to the documentation. Now we're going to dig in a little bit deeper and focus on medical necessity to start with. This patient did receive infusions and a duplex scan. Documentation indicated that the patient did present with pain of the right forearm, and then the patient was placed in observation for cellulitis. The coding does indicate the capture of cellulitis for the reason for visit, as well as the first listed diagnosis. In this case, we did fail medical necessity for the venous Doppler duplex, as cellulitis does not meet medical necessity. However, if the pain in the right forearm was added as a reason for visit code using M79631, medical necessity would be supported for the venous Doppler. The reason for visit diagnoses are important, even if it is a symptom, because it can help meet that medical necessity. A patient's presenting condition could be why a test is ordered prior to a definitive diagnosis being determined. As mentioned on the prior slide, sometimes the documentation is there to support the service. It is just not being picked up as it should, and this is where an organization could be losing revenue. So let's talk about the observation hours next. Who calculates your observation hours at your organization? In this scenario, we do have 10 hours of observation reported. Now, looking at the documentation, the observation order was written at 10:35 and the discharge order was documented at 19:20 with the nurse reviewing discharge instructions with the patient. So let's do a little math here. If the order was written at 10:35 and discharge at 19:20, that's 8 hours and 45 minutes. That is not 10 hours. Plus, the patient also left the observation unit to go for a procedure in the vascular lab. With observation services, we must account for the time the patient left the floor. Therefore, we know that the number of units reported for observation services are inaccurate, and we are going to figure out what are the accurate hours that should have been reported. Documentation is key when carving out time for observation services. Some facilities may have policies set that recognize the amount of time it takes for certain tests, and that time is deducted from the observation time, whereas others have to depend on the times documented within the note. Here is what we know in this scenario. The patient was given IV Toradol at 13:10, and then transport came and transported the patient from the observation unit to the vascular lab for the procedure. The documentation does not provide us with the time the patient actually left the unit. Upon return to the observation unit, the patient received another IV infusion of clindamycin starting at 15:30. We do not have a time associated with the actual return, but we do know that the patient had an infusion start once they were back. Therefore, in this case, we would need to carve out time using the times provided for that injection and infusion. The patient received the Toradol at 13:10. left the unit, the patient returned, received the clindamycin at 15:30, which equates to approximately 2 hours and 20 minutes. If we deduct the 2 hours and 20 minutes from the 8 hours and 45 minutes that we calculated on the previous slide, this would result in 6 hours and 25 minutes of observation time. Therefore, only 6 units of G0378 would be supported in this case. Let's discuss our last set of charges in coding, which is the medication administration. Stand infusions can be charged in the observation setting. So in this case, if we're starting with the clindamycin, we have 3 different infusions that took place. The first infusion comes out to be 31 minutes, and this is correctly reported with that initial infusion up to 1 hour, 96365. The second infusion is also 31 minutes, and this is not correct because it does say second infusion, but it does not mean that a second line was inserted, or at least we don't have that documentation to support 2 lines being indicated. Therefore, in this case, we would report 96366 for an additional hour of that same drug, and the 96365 XU would not be appropriate here. The third infusion started at 15:30, but we do not have a stop time. And since there is no stop time, we would have to then report 96376. And lastly, we have that IV Toradol. This is correctly reported with 96375. However, the units are incorrect because we only had 1 push of IV Toradol, and the push for the clindamycin would be of the same drug off from those infusions. So we're going to look at the changes all in summary now. For this scenario, we had to update our observation hours from 10 hours to 6 hours. We had to change the units of the new drug from 2 units to 1 unit. We deleted the 96365 because the documentation did not clearly indicate that 2 separate lines were being utilized, and we added the 96366 and 96367 to support the infusion services. We also changed our reason for visit from cellulitis to the reason why the patient initially came in, which was pain in the right forearm, to meet medical necessity for that duplex scan. So observation services are complex, but it is important that we get them right. We do not want to leave revenue on the table. So we're going to talk about the challenges with professional claims now. So think about who does the coding for the professional services within your organization. Are they coders or are they physicians? Common challenges that we do tend to see include either upcoding or downcoding the evaluation and management levels, critical care services charged when a patient is either noted to be stable or improving, missing charges for procedures and screening services that are rendered during an encounter. If you have physicians coding their own services, are their encounters checked prior to being billed? This is a question to ask because physicians are not coders, and we want to make sure that the coding is as accurate as possible when it goes out to the insurance company. We also see challenges with inappropriate modifier placement. We tend to see modifier 22 appended without the supporting documentation, modifier 25 appended to the wrong CPT or HCPCS code, incomplete documentation. This could include specificity missing from procedures, the assessment and plan being incomplete and not supporting medical decision making, When it comes to surgeries, we see incorrect CPT codes billed, inappropriate billing of multiple surgeries in one session. The CPT codes may differ from what is reported by the facility. And then another challenge are the inpatient daily hospital visits. So documentation may be incomplete, as encounters have to be standalone when we are billing for the physician services in an inpatient setting. And this tends to be forgotten a lot because they're writing short progress notes carrying over from one day to the other, but it's still a standalone note on that physician side. We also see split shared services inappropriately billed frequently. So ask yourself, do you have different teams coding? How do you validate the coding or the surgeries? How do you feel your coding accuracy is? Are you monitoring any type of accuracy? So I'm going to take you through a case study pertaining to professional claims. And the intent behind these case studies is just to surface the challenges and get you thinking about your processes and if you could have any type of revenue leakage. A physician note, we are going to review and ensure that everything is accurately captured when it comes to the coding. So in this case, the patient is presenting for follow-up of hypertension, hyperlipidemia, and diabetes. The provider talks about the patient being compliant with diet and exercise. However, the patient mentions the stiffness and pain of his right index finger. As we move into the assessment and plan, the provider refills prescriptions, orders labs for the hypertension, hyperlipidemia, and diabetes, and they provide a diagnosis of a trigger finger of the right index finger and also offers an injection. So let's take a look at the diagnoses and codes billed for this scenario. To start with the diagnoses, as I mentioned, hypertension was documented and it appears accurately coded. Hyperlipidemia as well as diabetes is documented, supported, accurately coded. Focusing on the trigger finger reported, the diagnosis that was reported does label it as unspecified. In the documentation, it states that the location was the right index finger. We could get more specific with the diagnosis coding, providing that exact location of the right index finger using M65321. So there is opportunity in this case. The evaluation and management service code, this looks good. We have stable chronic conditions. The physician ordered several labs, ordered some prescriptions, and this would support some moderate medical decision making. However, one challenge we see quite often is the lack of picking up additional procedures. And in this case, our provider did not report the trigger finger injection. We would want to add this injection with CPT code 20550 with the modifier for the right index finger, followed by also appending a modifier 25 to that evaluation and management code. And this seems like a lot for a provider to remember, right? So this is one large challenge among physician practices, and physicians are performing their own coding and they are not coders. They did not sign up to be coders, but surfacing situations like this makes you wonder how much additional revenue is being leaked. So surfacing these situations, just like this scenario, it's just a start. So whether your physicians are coding or if you have coders, think about, are chronic conditions being captured appropriately and to the highest specificity? Are evaluation and management levels accurately captured without upcoding or downcoding of services? Are all additional procedures captured correctly? Are modifiers applied correctly? Think about the facility and professional challenges we discussed. Do you have potential opportunity through any of these topics that we discussed today? Several hands touch an encounter, and several departments play a role in that revenue cycle process. It really does take a village to optimize revenue cycle performance. So here we have listed a few key players, but there are probably more. Does the process at your organization run seamlessly for all services provided from the front end to the back end? Do you have a committee or do you meet regularly with your key stakeholders who are involved in the revenue cycle? Having a revenue cycle committee with various stakeholders is a very common practice, as it does help surface areas of opportunity, discuss what is working well, where modifications can be made in the process. Overall, you are staying in touch with your revenue cycle rather than having a break in the flow that is not recognized immediately.
Let's spend some time talking about how to surface outpatient revenue cycle opportunities and solutions. So let's talk about some strategies to surface outpatient revenue cycle opportunities. On screen, you'll see some of our traditional um, strategies to surface opportunities. Claim scrubber may identify things that need closer inspection. Uh, Traditional coding audits can certainly surface opportunities. Denials from our payers, may surface opportunities as well. Downgrades. In facility ED&M levels, we're seeing commercial insurances downgrading. That might surface opportunities for an organization. Medical necessity write-offs can surface opportunities, either provider documentation needed to support medical necessity for tests done or missed coding opportunities. Monitoring of revenue spikes or decreases in revenue can indicate, opportunities. And physician complaints about perhaps their RVUs decreasing may surface opportunities for the revenue cycle. When you think about opportunities, think about what you're doing or what you've done to surface opportunities. Did you find some areas more challenging than others? And are there additional areas you focus on?
Discuss the strategies to surface opportunities. In this case scenario, we are going to audit a procedure to determine if all the reported CPT HCPCS codes are correct. And we want you to look at what was billed versus what was performed. Now, this is not an entire operative note, but it will provide you with the information to determine correct capture. There was an insertion of an endovascular vena cava filter, the 18 coat mandrel guide wire, the AM Platt super stiff wire, and the 5 French dilator sheath system. Is the vena cava filter insertion correctly reported? Yes, we have the procedure and we have the device. How about the guide wire, the C1769, is that correct? In this scenario, we're going to say no, because we actually inserted 2 different guide wires, so we do want to capture both of those supplies. Do you think this scenario is ready to be billed now? We mentioned earlier in our challenges that ensuring that you are capturing all devices can be challenging. So in this scenario, we are missing the capture of the dilator sheath system. This is not a completely fictional scenario. We are seeing where devices are not being fully captured within organizations. So think about how you make sure all devices and supplies are captured. Who enters those device codes?
So how do you keep your finger on the pulse of the outpatient revenue cycle, sustaining improvements that you made and surveilling for new opportunities? Some potential solutions for this are to perform ongoing audits, to update your charge master regularly, to be involved in contract negotiations with payers to have a very strong and robust denials management program. Make sure that frequent education and training is being delivered from the front end to the back end. Billers, schedulers, topics such as advanced beneficiary notices, training and education for coders, for clinical staff. Maintaining and enhancing EHR for better documentation capture can help. Evaluate process improvement opportunities, such as with inpatient-only procedures or advanced beneficiary notices, and then physician and clinician documentation improvement.
You have another scenario where a patient presented to the emergency department complaining of shortness of breath, palpitations, and they had quite a bit of workup done. So as we go through this and we point out what could be broken, think about what your solutions are. So here in this case, again, presented with shortness of breath and palpitations. In the end, the provider documented that the patient had palpitations, and that was what was reported for the reason for visit as well as first listed. We discussed the medical necessity case earlier. Again, we have a test that failed medical necessity. If that shortness of breath was reported as the reason for visit, it would have met that medical necessity. So now we have two situations where all conditions are not being reported. So if this was your case, do you think you should implement an education program, any type of training for the coders? We need to remind everyone that you can enter more than one reason for visits. As mentioned under potential solutions previously, failure to get an ABN could also result in a loss of revenue. Maybe this process needs to be fixed. Why are codes not being checked against tests that are ordered for medical necessity, or why are ABNs not being completed? So again, many people say outpatient is low dollars, and it doesn't matter. But those dollars add up, and you would be surprised how some dollars can actually accumulate to the millions if the process is broken and goes unrecognized. And we have seen this, especially with labs and CT scans, drug screen, urine samples in the millions, like 1.9 million loss. So we did try to provide a wide array of case studies to help you start thinking about your outpatient process, the medical necessity, the coding, the documentation, charging, because every organization has a different setup with how their revenue cycle process works. We're going to go through one more case study. We're going to say that you are implementing one of the previous potential solutions by performing ongoing audits. This case, the patient presents for an outpatient laparoscopic prostatectomy. So I have a very comprehensive operative note here. We're not going to read it in great detail, but what I do want to point out is what was coded versus some key points in the op note. So if we're looking at our procedure, we can see that a 55842 prostatectomy, it's retropubic radical with lymph node biopsy. This procedure is performed through a midline abdominal incision. So we have to think about our approach. So the CPT code that was billed versus what we read in the op note. So if we were reading this op note, we would see that two robotic ports, a left robotic port and a left upper quadrant assistant port, were all placed under direct vision. The robot was docked and dissection ensued robotically. Okay. Scooting down to the bottom, we can see that the prostate was bagged, robot was undocked, and the bag was removed through the peri-umbilical port site. So is this an open approach here? Think about your open versus laparoscopic. And the answer is no. You have a coding issue if this 55842 was reported by coding, and it should have been a laparoscopic procedure. Reason being, you have an inpatient only procedure, and this patient went home the same day. You just lost that revenue. In CPT assistant, just to give you a reference, the use of robotic assistance, hand assistance, or minor incision for any type of specimen extraction with or without any extra corporeal work is still considered a laparoscopic procedure. So in these cases, if you are performing those inpatient only procedures in an outpatient setting, you are losing that money. And we recently performed some work for a customer where we reviewed 13 cases that were coded incorrectly, and it was because of inpatient only procedures being coded when they were actually outpatient procedures. That was over $2 million worth of revenue that was a loss at the time because of coding errors. So think about your audit programs. Are they in place? Do you have policies? Where are your opportunities?
So just to do a quick recap here, we discussed the complexities of managing the outpatient revenue cycle. We explored challenges. We discussed strategies to surface opportunities. Now, how do you make sure what was broken does not break again? Because I say the revenue cycle breaks every day. So let's talk about sustaining and surveilling. We have, processes, auditing, looking at denials, creating metrics, and monitoring, which are all manual processes. Is there a better way?
Now we are going to talk about our approach here at Solventum, and we've incorporated our experiences from working with customers, listening to them, conducting our own research on how we can assist in the outpatient revenue cycle process and optimize the performance. What we've done is we've developed a solution to help assist you with your outpatient revenue cycle from both the facility and the professional settings. We've developed a 4-phase approach to help customers keep their arms around their revenue cycle and surface opportunities. The first 2 phases, analysis and assessment, they go together hand in hand. Phase 1 takes in 2 years of your claims data. It analyzes it against our metrics to surface the opportunities. And during that analysis, we will rank your opportunities based on a financial and a risk perspective. We then provide the customer with the findings and then move into phase 2, which is your assessment phase. In this phase, we perform a record review of the top areas that we have mutually agreed on with our customer and validate what we found within our solution. We provide the results of that assessment. We provide education based on the findings from phase 1 and phase 2. Moving into phase 3, this is implementation, our process improvement phase. Think about our medical necessity cases. We had scenarios where diagnoses that should have been coded and were not. At the same time, was an ABN completed if this was a failed medical necessity test? Is there a process issue, as mentioned earlier? In this phase, our team assists with finding the root cause through interviews and shadowing, assessing workflows, recommending process improvement opportunities. If you have thought about an outpatient CDI program and did not know where to start, this phase is where we would assist you in setting up as phase 1 and 2, provided you with your opportunities on where you should start. Where is that revenue being leaked out at? What department should you start in? Phase 4 includes our ongoing support, where we continue to take in your data quarterly, biannually, or annually and run it against our KPIs. Let's say you fix something and we monitor it. We continue the monitor to see if it stays fixed. Well, maybe we identify something that has broken since the last time we reviewed your data, and now we need to fix something new. This is our 4-phased approach. This Solventum approach, what does the customer actually get? So here again, just to reiterate a little bit, we intake 2 years of your claims data. We use that data and analyze it against our KPIs. Currently, we have 153 facility KPIs and 120 professional fee KPIs, key performance indicators. The customer will get the findings and recommendations, including opportunities. We also offer that ongoing monitoring as well as the feedback. On the right-hand side, I do have an example of a KPI. So this one, what we do is when we take your claim, we look at what was reported with acute conditions. So implications when you're reporting an acute condition in the outpatient setting, it could impact your HCCs. It could mean that it's incorrect coding or potential for medical necessity errors. Let's use the example of a stroke in I-639. So let's say that's reported within the office. And we usually know that typically if the patient is not actively undergoing or experiencing a stroke, it should be a history of stroke or maybe even a residual effect of a stroke. So what we would do is we provide you with the findings. So in this example, we provided you with over 6,000 claims where an acute condition was reported in an outpatient visit that should have been treated in an inpatient setting. And I use the stroke example here. What we can also do is break it down by physician. Who are the top physicians who continue to report this stroke in the office setting? So we help you identify those opportunities. Now, this is specific to diagnoses. We do have a majority of our KPIs that are specific to revenue and procedures. Like I said, 153 facility key performance indicators and 120 professional performance indicators. So this is taken in the 837I and 837P claims data. So I mentioned all of those key performance indicators that we have that are available. So what these consist of is just diving into several different service lines. And we have some examples listed here where we look at emergency department, endoscopies, behavioral health, observation services, chemotherapy, ancillary services. These are just some examples of the service lines that we have metrics that have been created for. A lot of different service lines can help surface opportunities for your revenue cycle. So again, we're looking at procedures, we're looking at the way that codes are being reported on the claims, your devices, your diagnoses. Where do your opportunities lie?
Talk about the benefits and outcomes of our approach. First, we can help customers achieve quick financial improvements. I say that it's not always, hard to fix things that are broken in the outpatient revenue cycle. Some are definitely harder than others, but they can be fixed fairly quickly. We can identify revenue cycle opportunities for facility outpatient departments as well as for professional services for those organizations that employ their physicians and are managing the professional revenue cycle. We can help organizations decrease their revenue leakage, improve their revenue capture. We, as mentioned, can assist our customers with surveilling and sustaining activities in improvements in the outpatient revenue cycle with ongoing monitoring by our Solventum consulting team. We can track customer progress on their improvements. We can provide them with opportunities to resubmit correct claims. We can help reduce denials and reduce rework. We can enhance revenue cycle staff and physician performance through education. We can improve clinical documentation as well as coding. I'd like to take a few minutes and talk about the outpatient scorecard that we've developed for our customers. Let's talk about the outpatient scorecard. For those of you that have been involved with Solventum for inpatient projects, you're probably familiar with our inpatient scorecard. If you are, our outpatient scorecard is akin to that. What we do is we provide a facility with a specific scorecard like the one you see on screen here. It contains 4 key facility outpatient revenue cycle metrics that we obtain from the CMS publicly available MedPAR data file. This MedPAR data file is published 1.5 to 2 years out. The next slide that we'll talk about gives a brief overview of these metrics. First thing that we present on the outpatient scorecard is the facility's emergency department E&M level distribution as compared to their state. As you may know, CMS allows each facility to use their own methodology to determine the facility's E&M leveling, which represents the resources used to treat patients. There are 11 guiding principles that CMS requires facilities to abide by when developing their methodology. And comparing a facility's distribution to the state's distribution provides the ability for some benchmarking. And if a facility varies from the state, it may be due to the resources needed to provide care for their patient population. However, it's worthwhile to examine the variance. Just a few questions. When was the last time your facility's leveling criteria was reviewed? If your facility uses an EHR tool to calculate the level, when was the last time that tool was audited for accuracy or updated? If your facility is experiencing pay or downgrades of E&M levels 4 and 5, why is that? Is there any portion of your emergency department revenue cycle that is outsourced? And if so, are you monitoring your E&M levels? Frequently, customers who outsource the coding of their ER revenue cycle tell us that they're not concerned about their levels, that their vendor handles that. The next thing that we present on the outpatient scorecard is the number of inpatient-only procedures done in an outpatient setting that occurred at a facility. CMS identifies 1,600 plus surgeries that can only be performed in an inpatient setting. This list of surgeries gets updated annually. When an inpatient-only surgery is performed in an outpatient setting, the facility receives no payment from Medicare for the entire visit, not just the inpatient-only procedure. Some of these procedures can have high dollar supplies or implants associated with them that would not be reimbursed either. Any number for this metric is a loss of revenue that, if identified quickly, could potentially be corrected and captured. There's numerous reasons why an inpatient-only procedure is performed in an outpatient setting. For example, there are process problems at the facility, such as patient is registered incorrectly or the patient is incorrectly scheduled for surgery. Intraoperatively, procedures can change from outpatient procedures to inpatient procedures based on what the surgeon identifies in the OR. And then lastly, procedures can be coded incorrectly, making them inpatient-only procedures when they should really be outpatient procedures. The next thing that we present on the outpatient scorecard are the number of observation claims over 48 hours at a facility. CMS does not reimburse for observation services greater than 48 hours because they expect a decision to be made about the patient's next level of care within that 48-hour time frame. There's no potential revenue that we can associate with this metric on the scorecard because the revenue loss is based on how many hours over 48 are reported for each patient. As you know, observation services are fraught with many issues and opportunities for improvement, such as physician orders are incorrectly written for patient status. Post-op patients are often placed in observation status inappropriately when they should be in an extended recovery status. There are coding and billing issues such as carve-out time for services performed in outpatient observation settings not being applied. And we frequently find missing charges for the administration of infusion therapy. And then there are problems with the appropriate assignment of Condition Code 44. And lastly, there's the concept of outpatient in a bed status, just to name a few of the problems associated with observation claims. The last thing we report on the outpatient scorecard are potentially preventable medical necessity losses. CMS denies service if they review a claim and medical necessity for the service is not met. The GZ modifier can be applied by facilities when they identify claim lines for services that they know will not meet medical necessity requirements and they have not had the patient sign an advance beneficiary notice accepting responsibility for payment of services that did not meet medical necessity. This modifier tells CMS that the facility is self-denying the service. CMS automatically denies the claim lines without any further review. Sometimes we see facilities with a high number of claim lines with the GZ modifier and sometimes with a low number. If a facility has a high number of GZ modifiers, I ask, is someone at the organization reviewing these claims? Are they reviewed at the code level or the service level or the department level? Are scheduled and non-scheduled visits reviewed? Who is responsible for adding the GZ modifier? How is that monitored? And what does follow-up look like if a facility has a low number of GZ modifiers? Is there a policy in place requiring the use of the GZ modifier when appropriate or not? Are there outpatient denials for medical necessity, and how are these denials tracked and worked?
I want to take a second and thank Sue and Nichole for being with us today and providing all this great information. If you are interested in learning a little more about outpatient and getting your own outpatient scorecard, please feel free to visit the link below and fill that out. And our sales reps, as well as most likely Sue and Nichole, will follow up with you. A couple of the other things we would like to highlight. CES is coming up. It'll be in July 21st to 24th in Orlando this year. We have more information coming, but did want to give that a plug to get onto everyone's radar. And if you are interested in learning more about some of our educational boot camps, we have information in the resource section. You can also click on the slide to find out more information, and here are some of the upcoming dates for the CDI quality and pediatric boot camps. I know you've just heard a lot from Sue and Nichole, but they're always happy to hear and work with you if you have issues. So wanted to share some information, and feel free to reach out to the team. Thank you all for coming, and we look forward to hosting you at the next quality webinar in May. Thank you.